Hi, everyone. My name is Jessica Farrell. I'm a pharmacist at Albany College of Pharmacy and Health Sciences and Albany Medical Center Division of Rheumatology. I'm also a faculty professor of pharmacy practice at Albany College of Pharmacy. I've worked in rheumatology for about 15 years, and today I am going to be talking about Voclosporin. Specifically, I'm going to be talking about the safety profile and how it should be monitored. Before I get into that, let's just talk a little bit about what Voclosporin is. It's a second-generation calcineurin inhibitor that was recently approved by the FDA for the treatment of lupus nephritis. It's structurally very similar to cyclosporin, but it does contain a modification of a functional group on the amino acid 1 residue that increases the calcineurin binding, resulting in about 3 to 5 times increased potency compared to cyclosporin. This modification also allows for it to be eliminated faster and have a more stable pharmacokinetic profile and more consistent bioavailability when taken orally. This also eliminates the need for therapeutic drug level monitoring, which can be really helpful because our patients with lupus nephritis have to get labs so frequently. They still need to get labs while on therapy, but if we're monitoring one less thing, that can be helpful. From a safety perspective, there are still quite a few monitoring points that we need to consider, but similar to other calcineurin inhibitors, voclosporin does seem to have less of an effect on lipids and glucose profiles compared to other calcineurin inhibitors, but we still do need to monitor those things. Prior to starting therapy, we want to make sure that patients' eGFR is not less than 45. It's not recommended to be started in patients with that eGFR unless the benefits outweigh the risks. Additionally, their blood pressure should be less than 165/105 when starting therapy, and once they are on therapy, you have the baseline eGFR, and then that should be monitored every 2 weeks in the first month, and then every 4 weeks throughout the first year, and then quarterly after that. It's also recommended that we monitor urine protein excretion as clinically indicated, so that really depends on the patient's lupus nephritis and their clinical status. We're going to monitor blood pressure every 2 weeks during the first month. We'll also monitor serum potassium, which, different from other calcineurin inhibitors, is only recommended to be monitored periodically throughout treatment. And then we're also going to monitor for signs and symptoms of infection. There is a warning for malignancy, specifically lymphoma and skin cancer, so we do need to keep that in the back of our mind. Neurotoxicity, pure red cell aplasia, and also QT prolongation. I will say, though, the QT prolongation is really monitoring in patients that have other risk factors for QT prolongation or electrolyte disturbances already. The issue with QT prolongation in regards to voclosporin was really only seen in patients that were on higher than recommended doses. So unless they have risk factors, that's not something that we need to be too worried about. Like I mentioned, compared to other calcineurin inhibitors from lipids and glucose profile, it does seem to be less effect on those monitoring parameters. So for more information on voclosporin and lupus nephritis, please visit the WRAP website or our WRAP ACE app. And I hope to see you at our annual conference in September also. Thank you.